ladies and gentlemen, and welcome to the South Warwickshire NHS Foundation Trust February board. Just before we get going on to the main business of the agenda, I just want to make a few comments. The first is our flag, our NHS flag at the Trust has been at half-mast today in recognition of Captain Sir Tom Moore and his phenomenal contribution to the NHS in terms of his fundraising. On behalf of everyone who works for the Trust, I just want to put on record our enormous thanks to Captain Sir Tom and everything he did for those in the NHS. I also just want to put on record the board's enormous thanks to every single member of the Trust who work on the front line or work behind the scenes and have done phenomenal work over the last 4 to 6 weeks, again, during this third wave of the coronavirus pandemic. The emotional turmoil and physical challenges that our staff have gone through to serve the citizens of Warwickshire are absolutely phenomenal. And the whole board want to thank you, as well as thank your families who've themselves made enormous sacrifices as mum or dad or mum and dad are having to go not just the extra mile, but day in, day out, serve in ways that aren't usual. So our thanks to the families as well. And also to the citizens of Warwickshire. We know that during the pandemic, we've had to prioritise coronavirus patients, and that has had an impact on some of our other services, and we know that causes distress as well. So again, the board are doing everything possible to get all of our services up and running in their entirety with the fast turnaround times that SWFT is known for. But obviously at the moment we are having to prioritise the coronavirus patients. And as Glenn will be touching on later, however, the trends are becoming better in that regard. But before we get on to the main business of the board, I just want to celebrate our autumn 2020 Going the Extra Mile winners, which is when we celebrate quite extraordinary performance. So the first person I want to celebrate is our clinical winner, and Donna McDonald. And Donna, I'm not sure, hopefully you're on the line, in which case I'll wave at you. But I just want to read out what the commendation about Donna said. And it said, Donna, for those of you who don't know, is our cardiac device specialist nurse. And the nominator commented, Donna has been consistent in her care and attention in answering all the questions this patient had and helping to guide her through some very dark times. She also noted that Donna always goes the extra miles to reassure her patients. During this particular patient's pre-op appointment, the patient jokingly requested that Take That's Greatest Day song be played during her procedure to help her relax. And Donna organised that. And the patient said she'll never forget being wheeled into theatre, listening to Take That, Gary Barlow in his full glory, singing Greatest Day. And 6 months later, the patient had to have another procedure. And again, Donna organised for Greatest Day to play again. And over a year after the patient's first procedure, the patient was having a particularly bad day, struggling with her mental health at home. And on that very day, Donna rang out of nowhere just to see how she was doing and spent over an hour on the phone. And Donna, that level of concern and kindness and love towards our patients makes me and the whole board incredibly proud. So we're delighted to give you a digital round of applause and celebrate you as our clinical Going the Extra Mile winner. Thank you, Donna. Next up, Shirley Duncan, our non-clinical winner. Shirley is our IT clinical lead. and she has been working exceptionally hard to complete all the tasks that have been thrown at her during these very demanding times. The nominator says she's always approachable, always willing to find time to support colleagues. And Shirley has the role of leading the health visiting electronic patient record programme. And the nominator commented through Shirley's personal skills of outstanding leadership, she's having a huge impact on supporting staff in transitioning to the electronic patient record, on finding the root causes of any data quality problems, and basically, which I think is one of the biggest challenges in the trust, is helping to improve the workflow coming out of the Lorenzo system for health visiting. So Shirley, on behalf of all of the board, a digital round of applause for you. One of our guests, John, you have your video on. Could you please turn it off? Thank you. It might affect our bandwidth. And then our final award winner is a team award, and that goes to ISS. And I think we've got Andy and Justin on the line to receive this award. And ISS won it for the vital support they've had in facilitating short notice patient moves to ensure patients can be admitted and treated in a timely way. The nominator noted on one particular occasion, a number of urgent patient moves were required at very short notice. And to facilitate this, a number of ISS staff came in to work and prepare ward areas. The team responded, the nominator says, in an exemplary way, despite the challenging circumstances. And undoubtedly, ISS, in a whole variety of ways, have done a great job in the ED department and generally supporting the trust during the pandemic. So the team, Autumn, going the extra mile award is to the ISS team. So round of applause to you. Thank you very, very much. So you can all go and relax now, Donna, Shirley, Andy and Justin, or you can stay with us in the board. And we have a full agenda today, and I do want to keep things going at a reasonable pace to help our executive colleagues get back onto the front line and look after our citizens. So I don't believe we've got any apologies for absence today. And have we any new declarations of interest? Please raise your digital hand if you have. Okie dokie. And then the minutes of the meeting held on the 2nd of December. Was everyone happy with the accuracy of those minutes? Please raise a digital hand if you weren't. Okay, on that basis, I will sign them off. Then on page 19 of the board pack, we have the action points arising. The first was on the Digital Health Board Quality Report. Glenn to bring an update on the Digital Hub launch. And that's included, but we had the Digital Hub launch, which a number of us attended. The Digital Hub in Stratford Hospital really is a fantastic facility, and for a trust of our size to have that sort of capability with our partners from SSC is really class leading. So great work going on there. The second was for Sarah to clarify the definition of significant investments within the terms of reference. That was done, and just for the avoidance of doubt, it's over £500,000, which requires board approval. Then under the Foundation Group Strategy Subcommittee from last summer, a regular slot to be dedicated to digital innovation. Helen, that's going to happen, so thank you for that. And then under the nurse staffing report, to amend the title of the nurse staffing report to ensure it includes AHPs and midwives. And Fiona, that's been done, thank you. And Glenn's chief executive report to bring a place-based clinical strategy, and that's on the confidential agenda for today. So looking forward to that. And then we've got some things coming up in the future, which are all carried forward. So in terms of the matters arising, are there any things I've missed? Okie dokie, thank you. So in terms of, first of all, our items for approval, we have the review of policy review group terms of reference. Anne Coyle.
Thank you, Chair. The amendments to the annual review of the policy group terms of reference are shown as track changes. It's been approved by January's policy review group, and the track changes really refer to the introduction of general gender neutral pronouns. So it is here for consideration.
Okay. Any questions or perspectives on those adjustments to the terms of reference? Please raise a digital hand. Everyone happy to approve? Please raise your hand if you're not. Okay, duly approved. Thank you very much. So, Glenn, over to you.
Thank you, Russell. So there's quite a few things in the report this month. I'm not going to go through all of the detail in there. The first item is really quite important. So alongside all of the really busy activity around COVID, there's also been some important changes happening nationally, proposed changes to the legislation under which we operate. So there's a consultation launched just before Christmas, which is now closed, and the consultation included some proposals that are set out here in the report, which I'm pleased to say we've been able to influence through involvement in some of the national and regional work. So fundamentally, it's moving away from the competition rules that we've had for a couple of decades now, it must be, across the NHS, into more collaboration. And it provides the opportunity for the NHS to work more closely in partnership with other key partner organisations. So particularly for me, the main highlight would be it does encourage the development of groups like ours for collaboration and sharing best practice at pace. It promotes place. So for us, that's South Warwickshire, or in the case of our community services, North Warwickshire. That place is the main building block through which partnership activity should happen. Integrated care systems will sit above that and will be involved where they need to be, but that place-based model is something we really support. We also support the development of the lead provider at place, and obviously have set ourselves up to be that through the strategy that we've had in place for some time. I think actually one of the governors asked a question ahead of the board meeting today about what are the benefits to the community if this legislation is put in place. And I think simply I would say it allows us to accelerate the strategy that we've been working to for a number of years now here at SWFT. So that kind of focus on population health, focus on place, focus on integration, and as the legislation actually is a removal of legislation rather than an introduction of new things. So we're supportive of it. Option two, there are two options in there. One option is just to continue to have an integrated care system as a board. I favour and support the option two, which is to create it as a body. By doing so, there's an opportunity for that body to be truly independent of any providers like us or commissioners in the system. But by creating a body, I think there's also an opportunity to review the scale of integrated care systems so they can be truly strategic. And that's something I know there's consideration being given to that across the country, but also in the Midlands region. Notwithstanding the need for us to work in partnership, it also continues the Foundation Trust model and the governance, the good, strong governance that comes from individual organisations is not lost within these proposals. So we will still be held to account for the things that we do as an organisation, and obviously in the way that we do that in a very public way through our public board meetings and our governors. So all of that's good. The new financial model will move away from the tariff that we've seen over the last few years, and I just note at the end of that section that we should make sure that we don't lose the focus on productivity, because we've been able to look at productivity much more by being more granular alongside tariffs. So the use of getting it right first time and other methodologies will continue. So we will see more of that over the coming year, Chairman. The intention is that this will be go through its parliamentary process with the intention of it being operational from April 22. I then have a section on our wheelchair services, and if you look at the scale of this, there's 3,500 wheelchair users across the whole of Warwickshire. And if we went back to 2017, there were some performance challenges with the wheelchair service, and they've truly transformed their approach using our QSER service improvement methodology, improved their efficiency, their effectiveness, their waiting times, and it's a real success story. So credit for them, the work that they've done. There's then a section on the Digital Innovation Hub, which was launched by Matt Hancock virtually. And as Russell has already said, there'll be some great work coming out of that, not only for us, but for the group, but for the wider NHS. Then a piece on testing, particularly about rapid testing and increasing access to that. An update on COVID vaccination, which has obviously come on stream since we last met as a board. Great work from the entire team on that. High levels of NHS frontline staff and local care workers been vaccinated on the Warwick Hospital site, and also our partners in primary care vaccinating using our Stratford Hospital site in particular for that, and also in Leamington. It will be great to see the increasing level of coverage from the vaccine. I talk a little bit in here about the 2-dose strategy, which has been talked about nationally, which I do support. Then on critical care, gives me an opportunity just to give a bit of an update on our COVID situation. So today we've got 51 COVID positive patients in the hospital, 8 in critical care. That 51 is a significant reduction from the position we were in a couple of weeks ago, where we peaked around 140, 150 patients. So it's been great to see that pressure coming off. It's still a challenge to manage with the different cohorts of patients that we need to manage in beds. But the thing I refer to here is the fact that our critical care facility has demonstrated its capacity agility by increasing our number of critical care beds, first to 175% of the norm, then to 200% of the norm, to go through surge and super surge, to both help the position in the Midlands, but also the Midlands helping London. So we've seen transfers of cases from London into the Midlands, and indeed for us, we've been supporting some Birmingham cases into our critical care capacity here. Not easy to do. It's relatively easy to increase the physical capacity, but the staffing pressure on this shouldn't be understated. But that pressure is applicable throughout the hospital, throughout our community services, and everyone's been doing their bit to make sure that we manage during COVID. And one of the reasons why we introduced a bit about here the rumour mill, which is our anonymous staff question portal, is we've added this functionality, which you can see there, which allows staff members to congratulate others and to say thanks for the superhuman efforts that people are putting in at the moment. And there's a screen snapshot there of some of the things that people have been doing. And then finally, the words that Russell just read out for our autumn Going the Extra Mile winners, clinical, non-clinical, and team. I'm happy to take questions at that point.
Thank you very much, Glenn. Very comprehensive. Any questions or perspectives to Glenn? Please raise a digital hand. Okay, Glenn has obviously been keeping all of the non-executives briefed. We had a session with Glenn this morning at 8:30, so thank you, Glenn. We'll move on then to the Integrated Performance Dashboard. Anne.
Thank you, Chair. The Integrated Performance Dashboard really illustrates the impact the continued COVID-19 response has had both on activity and performance at the Trust, and later on in the agenda we'll have an opportunity to cover that in a little bit more detail. We have in the period seen a deterioration in regulatory performance measures, And I suppose the context in which we have operated is our response to both COVID and non-COVID patients. And we haven't seen, as we did in the first wave that we saw, we stood down a lot of our elective activity, but we continued to deliver that over the period covered with the report. Glenn's referenced the partnerships and the work that we've seen, and that's been critical as part of our COVID response. It's been really reassuring in the Director of Nursing report just to really note that patient experience, despite the challenges that we have faced over the period covered, that patients continued through the Friends and Family test to report good experience, although in December it is noted that the response rate there was lower than expected. Our workforce really have been at the forefront of our ongoing response, and it's really positive to note the continued progress that we continue to make in recruitment to vacancies and the work that is underway to attract staff to join the trust. Happy to take any questions on that, and if not, we'll go into the detail of each of the sections.
Thank you. Anne, any questions to Anne, or colleagues happy to get involved in the detail? Glenn?
Probably just emphasise, as Anne said, whilst there are a number of red areas on the performance report, because we're obviously looking at some of the constitutional standards that have been around in the NHS for a number of years now, our relative performance to other providers in the NHS continues to be incredibly strong. So it's been a tough year for the NHS, but we're certainly at the top of the list in terms of all of those indicators, actually. So we'll go through the detail in a moment, but it's worth being aware of that context.
Okay, great. Thank you for that contextualisation, Glenn. Okay, we'll move on then to Fiona. Fiona, over to you.
Thank you, Chair. The only thing I wanted to pull out this month really was inpatient falls, and particularly those with harm. We have seen a slight increase in that over the last few months, but and that remains above a target for this month. But I preemptively want to say that has come down in January, reassuringly. We have done a deep dive, and there was a COVID effect in terms of more patients being nursed inside rooms, and the PPE making the clinical staff it more difficult to get to the patient in a timely manner. But the staff have adapted to that and are working through how they manage that on the long term, and have seen some improvement in months. Other than that, I'm happy to take questions.
Thank you very much, Fiona. Any questions or perspectives to Fiona? What's worrying you most, Fiona?
I think I've said before that my worry isn't one particular thing. It is the tiredness of the staff, and I was talking to some of my director colleagues this morning. It's about resetting after COVID, I think. You know, we have lifted some of the requirements for audits, such as the dementia, the nurse care indicators, the friends and family, through COVID, and we do need to restart that. And I suspect that there will be a dip in some of those, just because of they've lost the momentum of doing some of those basic standards. But as Anne said, the patient experience measures, the complaints, the feedback that we get from families is they still feel safe. They still have a good experience. We haven't had an increase in incidents per se, or of serious incidents. So I'm assured that it's safe. But we do need to reset the organisation in terms of our expectations in the near future.
Very good point. Thank you, Fiona. Colleagues, happy to move on then to Helen's report. Helen, over to you.
Thank you, Chair. I will try to put my camera on, but if you lose connection with me, then I will turn the camera off, because obviously the network problems are all my fault. What I did want to say, which is stressing some of the things that Glenn has talked about, and also that Anne has alluded to in her commentary. And this time of year is always challenging for us as an organisation as we work towards the usual winter pressures that we have, and particularly this year as we have COVID to manage on top of that. So the organisation has seen some considerable pressure. I'm not going to talk massively about the COVID effect because I do have more detail for that in my COVID summary later on in board, so I'll pick that up then. But I did want to highlight some of the good performance that we have seen for December. And so I think it is fair to say that from our recovery point of view, in recovering all of our elective services for December, we were either just below the 100% or exceeded the 100% of the previous year's activities for December. So the organisation had worked exceptionally hard in relation to recovering our activity. And the one that challenged us the most particularly was around some of our outpatient activity and relating to some of the elective inpatient activity that we were required to restore. But again, that was in the high 80% of the previous year's performance. So really strong recovery on that point. I think given where we are now, just to maybe preempt a question you might ask me about what I'm worried about, I am worried about the second phase of our recovery once we come out of this phase of the COVID pandemic, because the staff are tired and they've been working really hard through winter, through COVID. They didn't have a break earlier on in the year because we were straight back into recovery. So to go straight after a hard winter back into recovery again, I think we are all concerned that it's the same staff working really, really hard for the year, and that does worry me. I think that the other things that I wanted to highlight is that we have done some really great work in terms of our length of stay, our occupancy levels, and also our stranded patients data, and worked really, really hard across the organisation to be able to deliver some really best practice around those elements. And I will bring back the results of our perfect week into next board meeting, so you can see the best practice that we have delivered there. So RTT was strong in November and December, and diagnostic wait times were again strong, with some pressure on MRI, and that's because of that we've had a reduce in our productivity around the MRI scanner, just because the type of unit it is, but actually that's looking like that's going to recover really quickly. And you all know that the cancer standard is quite fragile. Some of that is in relation to patients really wanting to wait as we've moved into this third phase of the pandemic, and wait till COVID is over. But our cancer services have not stopped operating. So whilst during January we did need to stop non-urgent and non-cancer elective activity, all of our cancer and urgent work still continued, and so the staff have continued to work hard. I'm pleased to report that the emergency section rate has settled to much more of a normal rate, and actually has improved to 16%, which is the lowest that we've had in the last 12 months. So some really positive work gone on there within maternity services. We've seen improved turnaround times on the COVID swabs, and we know that that had caused us quite a lot of challenge during the early part of the pandemic, but they've significantly improved. And a really strong performance from our out-of-hospital teams in terms of working differently and implementing best practice. So given where we are for winter and COVID, I think that's very strong operational performance for the organisation. And I'll take any questions.
Thank you, Helen. Thank you for a very good introduction. And I know we've had some external validation of the great work we've been doing on length of stay, so well done there. Questions and perspectives, Glenn?
I'm just going to add that obviously we're looking still at the moment at the 4-hour performance in terms of ED performance. There are some new measures that are being consulted on nationally at the moment. They're likely to be introduced that will look at a suite of performance indicators, which we'll share with the board as soon as that becomes more certain of its implementation. But our urgent care system has done really well, and board members will be aware. Yesterday, unusually, I received a letter from West Midlands Ambulance Service saying that the performance of actually all 3 trusts in the group has been exemplary in helping them to release ambulances and speed up the ambulance turnaround times, which I know has been a real worry for them over this winter. But for them to write to us in that way, it was really nice to see, and it's good team working.
No, great. Thank you, Glenn. Any other questions or perspectives, Helen? Otherwise, we'll move on to Anne's report. Sue.
Hi, Helen. I just wondered about the introduction of 111 first, which is the first time we've seen it. And I just wondered what, from your perspective, what's going well? Is it building, and are there areas that need to improve?
Thank you, Sue. I will be as politically correct as I possibly can in that answer. From a national point of view, I don't think that's been a great success, and I haven't got a problem saying that, because there hasn't been a national campaign in terms of raising that profile. I think what we have done to support that programme of work is look very, very hard at what our directory of services are within the organisation, and also around what our same-day emergency care and our ambulatory pathways have been. We've done a piece of work with the GPs around raising the different ways in which the GPs themselves can self-refer into all of our other services without those patients going through ED. So in terms of it making us think very differently around how we have managed the organisation and what the organisation front door processes look like, we've done a huge piece of work which I think has been very successful. The NHS 111 bit still has work to go, I think, before that becomes an embedded and widely used service that the general public can use.
Okay, thank you, Helen. I think overall, though, the message to the public is the accident and emergency is there for you in an accident and an emergency. But please, use the 111 service if you can. Glenn, over to you.
Yeah, I was just going to comment on that. I think that one of the reasons why it's not had such a big impact on us locally is that we were already quite used to directing some of our GP activities straight into our medical assessment unit and giving GP telephone advice and avoiding patients waiting in A&E unless they absolutely needed to be in A&E. So, but elsewhere there were some quite traditional pathways which 111 has been able to shift, but we'd already been doing that for a little while.
Okay, great. Thank you, Glenn. Colleagues, happy to move on. Thank you, Helen, for all your hard work. Anne, over to you. Anne Poe.
Thank you. So Anne's helpfully referred to the ongoing work on recruitment, and that the pace picked up on that after Christmas, as you would expect. And the report sets out some specific information in relation to that. I wanted just to talk a little bit about sickness absence. So while it has gone up slightly, I think it's, and I do refer to the fact that it's not at the place that it was a year ago, but to give an indication of the impact of other absence related to COVID specifically, at the end of that report, I've just set out what a daily snapshot looks like, and that's a fairly typical day at the moment, with the impact of self-isolation associated with contact with a COVID infected individual, as well as the test and trace, and the impact now of shielding for this period of time. So there is pressure on the organisation, and you'll see that, as has been the case for some time, that anxiety, stress and depression is the main reason for absence. So we have an ongoing programme of support for our staff. We're trying to flex that as we listen to staff and understand what it is that would help them in relation to supporting their well-being. So that's ongoing, and it's a dynamic process that that hopefully is meeting the need as far as we can. That's probably all I wanted to say, Russell. Thank you.
Thank you very much, Anne. Any questions or perspectives to Anne? I think, like you've indicated, Anne, and I mentioned in my introduction, we are very aware of the emotional stress of the pandemic on all of our staff, and it's not just our thanks that we give them, but we do want to ensure that if any member of staff needs to reach out, that there's mechanisms in place for them to do so to get the support they need.
Absolutely. We are. So the only other thing I was going to say is we are also trying to ensure that our staff take regular breaks. So we haven't, fortunately, we haven't had to cancel annual leave, and we have in fact been positively encouraging people to take leave regularly. Yeah, no, great, thank you. So we'll move on then to the numbers. Kim, how are we doing with the money?
Thank you, Russell. I think given in terms of context of what Anne's briefed everybody on, and Helen in particular, around how the organisation has done in terms of the recovery of our activity, but also dealing with the current COVID pressures. We've done very well financially in comparison. I think we're pleased to report we've delivered a surplus of 391 to year to date, and that was against a deficit plan for the period of 447. As a result, we've forecast a break-even position back to the centre, and that's helping the STP deliver a reduced deficit plan for the rest of the year of £9.8 million. I think the three things to note really that are still outstanding are that the NHSI and E are still working through with the national team are the treatment really of three items, and that's the elective incentive scheme, the annual leave accrual, given the fact that lots of people have been unable to take annual leave, and also non-NHS income. We're working through with them to understand what does that mean and how does that impact on our bottom line. So when I've got an update, I'll obviously inform the board about what that means for us. We are in a good, strong cash position. Again, in the board papers, that's 47 million. So that's a really good position to be in. As I've noted to the board previously, that does represent a month in advance, effectively, that we've been paid. I think the issue at the moment is for next year. So again, planning and the usual planning and contracting round has been suspended for the first quarter of next financial year. We have got some discussions with NHSIE in terms of what does that mean really in terms of the allocations for next year. I think those are the main things I wanted to highlight at the moment to the board. Thank you very much, Kim. Questions and perspectives, Glenn?
Yeah, just picking up on the cash flow position, Kim, the chart under section 7.8 needs to be updated, doesn't it? Because it's based on an assumption that we move to the historical financial regime, because we, as far as we're at the moment, we'll continue to receive cash in advance, so it will not drop down to below 20 million in March.
Not in March. We have been told, though, that they are looking to suspend that. So we believe that they will cease to pay us in advance. What we're not clear about is which month that's going to stop. So I'm just waiting for further guidance for them to confirm that. So I think it will change. I don't know which month though. So, but they've told us that they don't intend for that payment in advance to continue throughout the rest of next financial year.
Okay.
Yeah. Thank you, Kim. Any other comments from colleagues? Okay, great. Thank you, Kim. We'll just touch, Charles, is there anything you want to pull out of the mortality analysis?
Nothing particular, Chairman. I think you know, mortality indicators remain very comfortably within the control limits despite COVID, and the medical examiner model is continuing to progress very well, and particularly the service they're able to give working virtually, I think, has been very successful. So nothing really to add from that.
No, great. Thank you, Charles. Any questions to Charles? Okay, so we'll move on then to the assurance report on recommendations following the Ocondom review of maternity services. This is clearly a very distressing report coming out of the review of the situation over at Shrewsbury and Telford. Sarah, thank you for joining us today. Fiona, are you going to introduce and then Sarah, or?
Yes, thank you, Chair. So Sarah, I believe, is on the line. So Sarah, come put on your camera when you're ready. So yes, just as a way of introducing, Sarah will take us through the detail of this report as our head of midwifery. But as you said, the Ocondom report, the interim Ocondom report, is difficult reading, and it gives us an opportunity both locally, regionally, nationally, just to take stock of where we are as individual organisations and as a system in terms of the safety, the culture, the leadership, the governance of our maternity services. There was a sort of standard template document that was mandated to be completed, and that is most of the detail within the report. Sarah will go through the reasons for some of the amber rating that we have summarised on page 3, which is the summary of the more detailed assessment. Some of those ambers are in our gift to resolve, and we'll be doing that as quickly as we can, and others do require some steer and national guidance, which we're awaiting, but obviously we will implement those as soon as we have that guidance. So I'm happy to hand over to Sarah to give you more of the detail.
Thanks, Fiona. Sarah.
Lovely, thank you very much, Fiona Russell. Just to say, I'm also joined by Lynn Ward, who is our acute services lead, and she's just shadowing me today, so that is why Lynn is here. And hopefully, dependent on Siganya Sukumaran's clinical responsibility, she is hoping to join us as clinical director, so she may join whilst go through the paper. Yes, so as you've both already said, this is, a really difficult read, and it's difficult because it regrettably echoes findings in previous reports, namely Morecambe Bay, so 8 years on, and if you took the front cover off, you're still looking at the same recommendations. So just to really highlight those key findings before we go through some of the assurances. What women are saying is, they are not being made aware of their clinical risks. They're not being given the full suite of birthing options. That's that paternalistic perspective, perhaps. They don't feel that they're being listened to, and the risks aren't being escalated appropriately. And then when things do go wrong, the report is indicating that the culture is neither open, honest, or transparent, and I think most distressingly, unkind at times. So I think what we're looking at over the next 12 months, we've got this report. It is an interim report. We know that there's going to be a further Ocondom report. We've also got Bill Kirkup's report on East Kent that's due out sort of the summertime this year. And I think there may be others that aren't well known about that will also be in the public domain. So we really need to take stock and ask ourselves, why is it, that we have got these repetitive failings within maternity services? What is it, we can do at a local level? What do we need to do regionally and nationally? As Fiona's explained, NHSE and I have prescribed the template for this assurance response. In my view, the narrow is quite the focus is quite narrow, and certainly what I will be doing going forward is to undertake a further piece of work to be able to sort of escalate and share with board what I think some of our local risks are, and I hope to share that with clinical governance at the next clinical governance board. And obviously along with that, you know, what is it we will be doing to mitigate some of those risks. So we just look at the executive summary, the 7 immediate and essential actions. I think as I was going through this, having been around and did the gap analysis, you know, for Morecambe Bay, I think it is really important, you know, this is an opportunity for maternity services to be much more critical about the service. And it's, you know, rather than, you know, just say it's okay, you know, when it's not, because it's an opportunity, you know, to push upwards, you know, particularly at a national level, to say, you know, we don't have the resource, you know, we don't have the manpower, and, you know, if you want us to deliver on all of these, you know, the scope of what we're being asked to deliver today is enormous. So the first one, the enhanced safety, it's a really complex template, and I think I thought it was complex, and I live and breathe maternity, so for anybody that isn't maternity, reading this paper I think is, you know, is a challenge in itself. But all of the areas other than the one that I've highlighted in the summary, we are meeting, I feel, around the enhanced safety actions. The one that I put that we're not meeting is around the peer review. So what this is asking is that for all of our sort of embrace cases, that we have somebody external to the organisation to independently review. Now, some are reviewed independently through HSIB, but not all meet that HSIB criteria. I don't feel that we can say that we are doing this. There isn't a national steer about the methodology for this. There aren't any standards to say what's expected. You know, is it an hour quick overview? Is it, you know, is it meeting with the families? Is it, you know, having a MDT meeting? So, you know, my pushback really nationally is to say we need a much clearer outline as to, you know, what it is that you're asking. I just did a quick calculation. I think if we were to do this properly, we'd be looking at 4 weeks of a clinician's time to review, and that's just our cases, but obviously we would need to do it across the LM&S and Coventry. Double the cases that we have because they're a bigger organisation. Helen, am I taking too long?
No, you carry on, Sarah. I'll tell you if you're taking too long.
Okay, sorry. So listening to women, you know, I think we do that well. We've had a really good comms strategy. We can always do better, and we are always, you know, challenging ourselves on how we can reach out and listen more to women. We work very closely with our MVP. The next one around sort of staffed training. This is a new ask that's come out of Ocondom, and it's a formal MDT round twice a day. We do it once a day. So we need to look at the processes of how we're going to do this twice a day. And again, we're waiting for sort of further guidance as to exactly what this needs to look like. But I think it should be a fairly quick, should be able to do it fairly quickly, you know, within this quarter. Managing complex pregnancies, again, you know, we are green on this in terms of, you know, our current sort of pathways, but we know in the next 12 months that the maternal medicine centres, you know, will be up and running, and there will be different pathways to what there are now. But those details and how that's going to be funded isn't clear yet. So again, you know, we need the national steer, but as it is what we have at the moment, we are on track. The risk assessments throughout pregnancy, again, most of these, you know, I am assured that we are compliant with. The only element is around the personalised care and support planning. But again, we are waiting for national guidance on this to be able to benchmark and ensure that actually we're auditing against those standards. That will be coming out soon. I know that because I'm on that national work stream and I've been involved in writing that, but it's not out yet. The fetal monitoring and well-being, again, we have and have had for a long time a midwifery lead and an obstetric lead. But again, it's really vague nationally as to, are we all benchmarking and monitoring the same? Because the only steer is in Saving Babies' Lives, which is 0.4 for a midwifery lead. There's no guidance on what that looks like for obstetrics. So again, for me, this is an opportunity to say, you know, to regional and national, please, you know, give us a little bit more clarity around some of these asks. The informed consent, again, I think we do sort of well. We could do with updating our trust website. The Chelsea and Westminster is an exemplar. It would be nice if our website could reflect theirs, although all of the information that women need around the services are currently on the website. The maternity the workforce, we are birth rate compliant. And that was last done in March 2020, and that has been funded. So again, that is green. The leadership, again, you know, that is on track. That is being currently reviewed. We've got a great MDT team. It's really been strengthened over the last couple of months with Siganya as the clinical lead and Dr. Radhe Raghavan as the AMD. And we've got a new Labour Ward lead starting, Amy Fawkes. Sorry, that's a
thank you, Sarah.
Run through.
So
No, that's great. Thank you. Fiona, is there anything you want to say? Otherwise, I just want to say something and then invite comments.
yeah, I think possibly because Sarah hasn't explicitly. When we've talked through this, Sarah, and I specifically said to you, what's the level of risk here? And we both feel assured that our, broadly, I just want to state publicly to the board and to our public that we do believe our maternity services are safe, and that an Ocondom or a Morecambe Bay would not happen at South Warwickshire NHS Foundation Trust. We're in a very strong and good position. I think, as we always are, we're being very transparent about our gaps. Driving, and Sarah's, very strong drive for continual improvement, lack of complacency, and honesty about our current position. But I don't want anybody, the public or the board, to go away, unduly worried about our maternity services. We are in a good place, and we're in a strong place, and we're compliant against most measures. What Sarah is saying, we could still do better, and that's a good thing.
No, absolutely, and I can see Sarah nodding in agreement. And Sarah, I think it is, it's great the sort of national profile you've got in aspects of this, and I would very much want us to aspire and ensure that we improve over time the quality of what we do, because at the end of the day, we're an outstanding trust and we should be an exemplar in all areas of our service. So it's great the sort of ambition and demands you're sort of putting in front of us, Sarah. Thank you. So questions and perspectives. Helen, first of all.
Thank you, Russell, and thank you, Sarah. I've just got a couple of comments that I want to say as an old midwife. I'm going to class myself as an old midwife because I think I am. I think it's a very refreshing view on the report, Sarah, and I think if the board cast their mind back to the training that we had this morning, we have not been complacent as an organisation. I think we've been very transparent and open, and not gone into this thinking, oh, that could never happen here. So Sarah's done a remarkable job in terms of really that comprehensive view of our maternity services, and I think that has provided us with some assurance. So there's nothing in that report that says this is absolutely awful and the public shouldn't be assured, because they absolutely should. So I think that review on our maternity services with a critical eye has been excellent. And I think we just have to cast our mind back to a number of maternity reviews that have happened over the years, and I think it is right that we are critical and we do pull out those finer points, because we are always striving to improve our service. So I just wanted to say thank you to Sarah for her leadership on this, and also the national influence that you have as well, Sarah. So thank you for bringing this to the board, and it is, you know, I feel very assured that you know, it's in safe hands with you and the team, and that your review of those services it has been with a fine tooth comb and a critical eye. So well done.
Thank you, Helen.
Thank you, Helen. Charles.
Yeah, thank you, Sarah. I think that was a great overview. I just occurred to me, though, as you were talking, and with particularly the national hat on, given the number of these problems and the number of these reviews, is there a national problem with resource? You know, is this could do better, or is there a systemic problem that maternity is underfunded nationally?
I think it's a very good question, Charles. Yeah, and this is part of sort of my role that I've been asked to look at, you know, the pledges that the government have made, you know, in the subgroup for the Health and Select Committee, to ask, you know, have we made the right maternity pledges? Are they resourced? And do we have the workforce to deliver them? So I think there are definitely challenges around workforce in particular, and the way we deploy workforce that needs to be addressed going forward.
I think the other thing, though, Charles, and we did touch on this morning, we had a board workshop for members of the public on risk management, and we were emphasising the importance of open, transparent and a learning culture in an organisation. And I think one of the things in both Morecambe Bay, Ocondom, mid-staffs, one of the things that was very clear was that there wasn't an open culture where people could talk. There wasn't transparency and discussion about problems, and there wasn't a learning culture and a willingness to change. And I think one of the things citizens of Warwickshire can gain great assurance of is SWFT is founded on the bedrock of those three values. Just keeping things going, because we do have a lot to cover this afternoon. Glenn?
Yeah, congratulations to Sarah on getting on that national expert panel. There's only 4 on that panel, so it's great that you're on that. And I really would encourage the panel to complete the work that you've described, because one thing that really worries me about this is no sooner had this report landed than many trusts were declaring themselves fully compliant with the recommendations in the absence of any guidance about what some of them meant. When you're challenging yourself and you've got the kind of standards that we've got, we are quite rightly going to say we've got more work to do in these areas. And so I think nationally it would be useful if this is what we meant by these, then follows this up, and then people can have another look to see whether they are being complacent, because I think some are. Because if all of those reports have told us there are improvements to be made, and even in the very best services there are improvements to be made. So I think we shouldn't be complacent. The one thing I think we could probably look at, though, is when you talked about the peer review issue, I'd encourage us to have a look across the group on that one. I think sometimes within LMS arrangements, neighbours are a bit too near to each other to be independent. So using Y Valley and using George Eliot may be a way of helping that independence. And so it's truly a view about the safety standards within the service. But keep going with the national work, and we'll keep coming back to this, because as more guidance arrives, we need to check whether we're as compliant as we thought we were or not.
Yes, thank you.
No, absolutely. I just, building on Glenn's point, I would be very unassured if I was I was going to say pregnant mother, with any organisation that was saying that they were green on all of those 9 issues. I'd be very unassured by any organisation who had that level of organisational arrogance. And finally, Rosemary, then we'll move on.
Yeah, thanks. Thank you. And Sarah, I think Charles might have almost asked my question. It was really from a national perspective. We know that the UK lags well behind many other countries, particularly in Europe, in terms of our maternity safety. So do you believe that, you know, if everybody really implemented these recommendations, would that make a difference, or is there more in terms of resource or other?
I don't think I fully know the answer to that. I think if I had to sort of my quick answer to that, and I suppose this is, you know, what the panel will be looking at, you know, is that the ask is too big. I think we need to narrow the ask and really focus, you know, what it is that we want to drive and change and do that well. I think we need to look at the resource. I don't think it's adequate, you know, particularly staffing, but it's not just the staffing, it's, you know, how, you know, staff are deployed. But when you're asked to make, you know, such huge changes, you know, this is a massive transformation programme, really. It's actually having the additional staff, you know, to help make those changes, so clinical staff can focus, you know, on their clinical roles, and you need some expertise, you know, to support the change management.
Okay, great. Really good conversation. And Sarah, as we've said, thank you very much for taking the lead. I'd like this to come back as an update, Fiona, at the latest for the August board. If not before, but that can be our long stop. But Sarah, good luck with the national work. Thank you for your passion and commitment and leadership, and we look forward to seeing you soon. Thanks for joining us as well, Lynn. Okay, moving on then to the Audit Committee report for the 9th of December. Rosemary, is there anything you'd like to add?
Thank you. I say this was some time ago now, but really I guess the real focus was on some of the external audit work. There's a lot of uncertainty at the moment, or at the time we met, regarding new standards coming in place. I think it's probably going to mean more work from the auditors in terms of their value for money audits, far more scrutiny there than we've seen in the past, and overgoing concern where there's going to be much more focus on financial sustainability. So we have another meeting next week, and I'll brief you next month on the outcomes.
Thank you, Rosemary. Any questions? Any questions to Rosemary? Rosemary, if you could take your legacy hand down, that would just help me. Thank you. Moving on then to the Clinical Governance Committee reports for the 9th of December and the 13th of January. Bruce, anything you particularly wanted to pull out?
Yes, I'd like to make a couple of comments on the 9th of December one, please. To say for the commenter that we are operating the clinical governance in concise mode so that our executive colleagues have more time to deal with the pandemic. That means for members of the public that we try and get all the papers in so people do all the usual work, but we try and only discuss the really high priority ones, thus completing the meeting in a much shorter time. We made a comment on the 9th of December about the pathology network continued to be an issue in diagnosing COVID-19 in a timely manner. And I think since it was December and we're now February, a little bit of a verbal update appropriately would be good from someone, please, Glenn, Anne, or whoever. And the pleasing thing that we have a joint drugs and therapeutics committee with George Eliot in the foundation group, I think is a great move. The strength of the scale that we have. And I don't have anything else to comment on that one. Colleague Sue chaired the January one. So can I pass to her if she wants to make any other comments, please?
Thank you, Sue.
Thanks, Bruce. The only thing I wanted to draw attention to was the merging of the Clinical Governance Committee with the Quality Committee of the of South Warwickshire commissioners. So I'm really pleased to say that the trust is really pushing forward with integration with our partners there. And whilst the terms of reference will evolve, it's really great that we've been working together for some months now, and now we're at the point where we can formalise that.
Thank you, Sue. Glenn, I think you wanted to just come back on Bruce's ask for an update.
Yeah, to be fair to UHW, they did have some equipment challenges over the last period, which have made it difficult for them to deliver the PCR turnaround times that we need. That has improved a bit. There's been better deployment of rapid testing. Again, there's been some national supply issues with those products. As you know, I sit on the national board on that, representing the region, and we should be able to ensure we've got sufficient supply by next week, I think was the promise. There's a meeting taking place this afternoon, which I'm not able to join, but hopefully that will be resolved by then. But I think there's a wider point here, Chairman, which is that I don't think we've had a meeting of the pathology network for quite some time now. Obviously, COVID has occupied all of us, so it's probably worthwhile encouraging our colleagues at UHW to stand that back up, because there are issues relating to this, but also relating to cellular pathology that we do need to resolve.
Okay, Glenn, if I can ask you to go ahead and approach UHCW to make that happen, thank you. Helen, you've got your hand up, then we'll move on.
Yeah, thank you, Russell. I actually did put something in the Director of Ops report around the turnaround times for COVID swabbing, and so we have seen over the last 2 months a significant improvement in the turnaround time for particularly around the UHCW, the lab there, in terms of their turnaround times. I think what is fair to say that some of the delay in the turnaround time has been some housekeeping required within the organisation. And so if we think about what that end-to-end journey looks like for the swabs, half of it sits in our part of the organisation. So we've done a considerable piece of work to turn that around and improve those. And we have daily reporting now, and we have had for the last 2 months daily reporting on the turnaround times from UHCW and their CWPS and their capacity. So I'm assured it is in a much better place. Some of the challenge that we do have, particularly around the rapid testing that we have on site, is there is a national shortage in terms of the consumables. But what CWPS have done is divert additional equipment to us, because we have because they are critical to our pathway. So you know, that working relationship is now much more improved, and there's more detail to that if anybody wants to look in the Director of Ops report.
Thank you very much, Helen. Colleagues, happy to move on then? Thank you, Bruce. Thank you, Sue, for that update. So we'll move on to the Foundation Group strategy. Sorry, we won't. We'll move on to the NED Finance and Performance Committee report. And for members of the public, you'll notice when Simon comes on screen, he has the most impressive book collection of anyone on the board. So Simon, can you give us your update, please, from the 26th of January?
Yes, thank you very much, Russell. So this covers two meetings. The last one was yesterday, and the other one was on a month before. We are, as Bruce said, we are running foreshortened meetings because of the challenges in the system around COVID, but nonetheless they're positive, and they are giving a significant level of assurance. I think we're assured that we're financially in control. We're assured that we are operationally in control, and we're also assured that still, in spite of all the challenges around COVID, we're still looking forward to think about what good looks like in the future in a post-COVID environment, which is good. I would have mentioned turnaround times on testing, but we've just done that one quite effectively. But the one that really has been striking a chord for some months, and particularly at yesterday's meeting, is around staff. And I think the commitment we've had from our staff is exemplary, but it also remains clear that we cannot ignore the pressure that they're working under and the need to give them some time post-COVID to come up for air and recuperate. We referred to it at yesterday's meeting, and we have several times already today about a fire break, and I think that's an important thing before we press on and try and return to normal service in a post-COVID world. I think that's the most important point to make for me today.
Thank you very much, Simon, and thank you for the comments on assurance. Any questions to Simon? Thank you, Simon. We therefore will move on to the Foundation Group Strategy Subcommittee. Chris, anything you want to pull out of your report?
Yes, thanks, Russell. Just to add that we had a meeting I think it was last week or the week before, really good progress in terms of the joint working. Glenn shared the group objectives, and whilst they were agreed, we just said the wording needed to change and be less technical. And I think it was really pleasing to hear the progress around digital update from Andy, although it's a lot to take in. So we've agreed that he should be offering a monthly briefing to each of the trusts, just in order so that everybody and the wider audience of staff within the trust can see the progress that's being made with the digital strategy. And then finally, I was really reassured by the report from Kim and colleagues around shared services, and a report will come to each of the boards in March, but I was reassured, particularly with the context and the focus on staff.
Thank you very much, Chris. Any questions to Chris? Okay, thank you very much. And again, just for citizens and members of the public, the fact that SWFT is part of the Foundation Group really does put us at the forefront of being able to identify and share best practice at pace across all the various different things we do. We'll therefore move on to the Capital Programme quarterly update. Sophie?
Thanks, Russell. It's been a really busy year for Capital in terms of it's been a really positive experience of being able to access national funding, but the need to then respond at pace with some of those projects hopefully is shown in this report. So there's certain projects we were planning to do that we weren't able to do, but actually we've done a tremendous amount to be able to provide our clinical teams with the right environment moving forward. I think in terms of an update today around one of the schemes, which is very positive news, which is that we did learn from the planners we will get our planning permission this week for the car park, the long awaited car park that we've wanted to do, which will make such a difference to our staff when we talk about stress and well-being, just the ability to be able to access car parking as we move forward. So that's really positive, and the council have really worked hard with us at the end to turn that around. We have started as well to do our capital planning for next year. It's another ambitious programme, and we now go into the conversations with our system partners to prioritise that. But we've done quite a lot of early work to understand where those needs are for the next year, for us to continue to be able to respond with our estate. I'm happy to take any questions.
Thank you, Sophie. Just before I invite questions, and Glenn, if you want to correct anything I say, and one of the challenges we've got as we move forward on our ability to be solely in charge of where we choose to allocate and spend our capital is that as part of an integrated care system, we need to work with our partners far more. So some of the things that we may want to do, we may have to prioritise in the context of what our partners and ourselves think are best for the system. So I think members of the public need to be aware of that. Rosemary.
Hi, thanks, Sophie. And I know you've all been incredibly busy. It's a great, it's been a great year in terms of achieving so much in terms of development. However, I suppose it's a question I often ask at this time of the year. There's still, you had a big budget for this year, but there's still quite a lot still to deliver. There is a lot to deliver in only 2 months of the year. How comfortable are you that you will be able to achieve the value? And I've just forgotten what the value is, but I think it's at least 10 million pounds. And if it's not achieved, is there a risk to the organisation that with the new STP potential limits that we could lose out on some of those opportunities?
Yeah, so we've done quite a thorough piece of work, Rosemary, with the leads this year around really trying to understand where they're going to end at the end of the year. That being said, we are still we have been impacted on things like deliveries because of delays for Brexit. So if you look at the radiology project for Stratford, even today, learning that we've got another delay because of one of those pieces of kit. So I think that this is the kind of best guess that we've got at the moment of where we're going to land. But there is some risk around it. In terms of then schemes And the other risk, around that is because we've done so many projects this year, there are a number of them that are due to finish at the end of March. So endoscopy, Stratford radiology, and they're some of our bigger ones. So I think we will see big spend now in the last 4 weeks. And Kim and her team are aware of this because it's going to be really critical that we turn around the kind of administration on some of the invoices, etc., as we come towards the end of the year on the spend on the capital programme. In terms of then the risk to next year's programme, I think none of these schemes will not have necessarily started, but picking up on Russell's point, we do go into a very challenged period with our partners on capital next year. Some of our colleagues around their core infrastructure around theatres in particular. So that would be the risk on that.
Sure. So yeah,
okay, I really need to keep the pace going now, guys, because we are running late. Rosemary, is there another point you wanted to make?
No, just keep going and making sure that you really power through to get all the invoicing.
Thank you. Glenn?
Yeah, just to clarify the point on next year, I mean, the legislation I referred to earlier at the moment doesn't appear to change the rules around foundation trusts, and certainly that wouldn't be in place until the following April if it was. Problem is, though, so we saw earlier we have cash reserves, and we've incentivized clinicians to be efficient so that we can build those up to invest in the projects that are listed here and some new projects for next year. The problem is, if we use our financial freedoms as a foundation trust and spend our capital programme, it will reduce the amount available for the non-foundation trusts, and all the trusts around us in the STP are not foundation trusts and therefore will be held to a maximum capital spend. So it's we've got to be a good system partner here, but we could be unpopular if we used our foundation trust freedoms to the full.
I think the other thing, Glenn, again, for the avoidance of doubt and for members of the public to be aware, the consequence of that is unless we get on and do capital spend, we're in danger of having to limit how much capital we can spend in the future for that reason. So anything which is delaying our projects at the moment is deeply unhelpful. Moving on then, thank you very much, Sophie. As Rosemary said, a great year of being agile and making stuff happen. If we can pick up the pace, please, executives, because we are running late now. The patient experience quarterly report, Fiona.
Thank you, Chair. Just want to say that the report hopefully highlights good performance to the board and the public in terms of patient experience. We've continued in this quarter to have good feedback generally through PALS, bereavement and complaints, with a small number of formal complaints, which is our strategy. If I remind the board that our principles are that we engage with families and patients enough so they don't have to put pen to paper and write a formal complaint, because that just adds insult to injury really, and try and resolve any concerns at a local level. And pride ourselves in that low number. But when we do have complaints, that we answer them in a timely manner, and we learn from them at every opportunity. So just that as a summary, really. Happy to take any comments or questions.
Thank you, Fiona. Good report, particularly in such challenging circumstances. Any questions or perspectives from colleagues? Sue?
Just a quick one, Fiona. You mentioned in your concerns the high number of calls from patients inquiring about follow-up, and we've already talked in this meeting about the fact that there are more than usual patients waiting for follow-up. Am I right that we would encourage patients to call if they're concerned about their condition in any way?
Yes, absolutely. And we had that conversation, didn't we, at the serious incident meeting. We have had an increase in serious incidents about loss to follow-up or delayed treatment, and so the executive team are going to pick up a piece of work to action some of that learning throughout the organisation at pace. But yes, the principle is that clinicians, clinical teams should be encouraging and informing, proactively informing patients that if they're worried about being forgotten or having a delay in their treatment or their condition changes, that they should be in touch with their clinical team.
Thank you.
Okay, I really want to keep the pace going. Helen, is it a quick one?
It was just to give the board some assurance around that. So there is a national requirement for us to contact all patients on the waiting list, and you've seen from my report the considerable number of patients that are on the waiting list. So that work is in hand, particularly those patients that have been working a long time, waiting a long time. And we also have some plans in place to use technology now moving forward to regularly send updates to patients. There is also an email address that patients and GPs can email into if they've got concerns about either their wait time or their condition deteriorating. So there is quite a lot already in place to be able to capture a lot of those, but it will take some time for us to make sure that we're regularly getting in contact with every patient that's on the waiting list due to the nature of the impact of COVID.
Thank you, Helen. And I mean, just standing back, it is quite phenomenal. We've done over 10 million vaccinations, with people being called into vaccinations centres and to GPs and to particular hubs in the last few months. And quite clearly, the competence and capability of the NHS in terms of this whole area of reaching out to customers and patients and citizens is increasing at a phenomenal rate, which the NHS should be incredibly proud of. We move on then to the CQC update, including the Insights report. Back with you, Fiona.
Yeah, I just want to start with an apology. This report went to clinical governance before it came here, and I'm just conscious that I picked up that my executive opinion hadn't changed, and so that was the executive opinion I gave to clinical governance committee, and we did resolve. We have since resolved the issue about the NIV service. Really, that has been resolved with solutions and changes that we've made to the respiratory service due to COVID, and so isn't currently an issue. So just to give you an apology and update on that. Otherwise, our CQC Insights remains fairly stable in terms of the data that they hold. There is in month always a slight deterioration in one thing and a slight increase in other, but it generally remains stable. We have continued to have engagement meetings through COVID, both with me and some of the other clinical teams as well. And generally, CQC feedback has been positive around those meetings, and they feel assured that our services are still safe and effective. Just to note that we have closed the action plan now from the previous inspection.
Super. Thank you very much, Fiona. I think you've got a legacy hand up, Sue. Any questions or perspectives to Fiona on the CQC update? Okay, thank you, Fiona. Continue to keep us briefed. And then the Digital Health Board quarterly update. Helen.
Thank you, Russell. I just want to highlight three things. We have finally gone live across the whole organisation with our electronic prescribing, and that's taken us a considerable amount of time to get there, because it's not an easy task to do to move from paper to a digital solution. So that was really pleasing to see completion of that. The next sentence of the executive summary is a mistake, because our system for the National Early Warning Score is called SEND, and there isn't an abbreviation from it. That's what the system is called, rather than the Special Educational and Needs and Disability that's in the report. So we have now gone live with News 2, and again, that was another challenge for us within the organisation, and that went live just prior to Christmas. And then the final thing that I wanted to highlight was that our patient portal is about to go live during this month. And so that's a really transformational piece of work for us in terms of how we communicate with patients. And given some of the things that we've been talking about today, particularly around follow-ups for patients and appointments, We've now got a system in place where we're able to communicate electronically with patients if they so wish to. So some really exciting times moving forward.
Thank you, Helen, and particularly in the context of everything that's been going on with COVID. Our IT colleagues and everyone involved on the digital side have done a phenomenal job. Any questions or perspectives to Helen? Okie dokie, looking forward to the patient portal, Helen. Then the COVID-19 and winter plan update, back with you, Helen.
Sorry, I switched myself off prematurely, sorry about that. Just a couple of things that I wanted to highlight then out of the report, because I am conscious of time, so absolutely understand that we will have read through the paper, but I wanted to really set out some of the challenges in a little bit more detail that the organisation has faced, trying to balance our winter planning, the things that we normally see coming through into winter, our COVID pressures, alongside us having to, or the right thing to do, definitely around adhering to strict infection prevention and control measures. And actually that's created a bit of a perfect storm for us. And whilst winter hasn't particularly impacted on us as greatly as we thought it would have done, because many of the measures that we have in place for COVID have, I think, impacted on us in terms of flu and then some of the other infectious diseases that we may have seen during winter, such as norovirus. So we know that hand washing, social distancing, and making sure that you're not coughing and spluttering on people do make a difference to those things as well. So whilst we have run at a much lower bed occupancy than we would have normally seen, the challenge for us has been, have we got the right bed in the right place for the right pathway in relation to our infection control measures? And that has what has caused the challenge around our flow. And so I'll just turn your attention to the second page of that report, where you see our 50-bed challenge modelling chart. And I often present this during winter, so you will see our predictions in terms of what our winter should have looked like, and really where we are in terms of our actual bed requirement in the green line that sits underneath that. So as you can see, we have managed well below our normal bed base throughout winter, and including that COVID challenge. So we had predicted a greater surge on our beds if we had a normal winter and COVID on top of that. So much of our modelling that we have done, some of the best practice and the initiatives that we have put into place have really seen us quite well through winter. This pressure has impacted on us, though, as we have talked about, particularly on our 4-hour A&E target. And again, that's not really that we haven't got a bed to put a patient in. It has to be the right bed for the right patient at the right time. Because we have had to stop a number of elective pathways, then we have seen an increase in our number of 52-week breaches, but we are keen to move that forward as quickly as we can to address that. And Glenn has already mentioned the challenges that we have had on our ITU capacity, and actually what we have had to do is use theatre staff and other medical staff to be able to support ITU. So that consequently has meant that elective activity and operating has had to cease, because we are required, our surge capacity in terms of that physical footprint has been into theatres. At the time of writing the report, I didn't really know whether we were through the surge or not, but early signs are telling us now that we are through that surge in terms of hospital admissions. We are just seeing the tail end of our surge through ITU, because that does have a time lag compared to those numbers of hospital admissions. And I've also put into the paper some of the plans and mitigations that we have in place to be able to support us through winter and COVID. So I'll just take any questions.
Thank you very much, Helen. Very comprehensive. And I think Glenn used a phrase earlier on capacity agility. And that's one of the things you've clearly demonstrated and will need to demonstrate going forwards. Any questions or perspectives to Helen? Okie dokie. So moving on then to the infection prevention board assurance framework for COVID-19 in the checklist. Fiona, we've obviously had the opportunity to see this. This is a very important and comprehensive piece of work. Anything you particularly like to pull out?
No, I think at the time of the report, as I said in my executive summary, I was still slightly nervous about the testing, but that has improved, as Glenn alluded to, in the last month or so. So I think we're in a strong position. I think I've been assured going through these standards that have been laid out by NHSI and CQC related to COVID that we have covered everything off and are implementing that guidance robustly. We've increased in the last 2 months since we've had some outbreaks of COVID in our hospital wards, additional training and auditing, I think, and obviously going through root cause analyses and investigations on that, on those cross infections. But I'm assured that we are compliant with all the national standards and more.
Fantastic, thank you, Fiona. Any questions to Fiona on that checklist and the assurance framework? Yeah, I'm sure, Fiona, if you can pass on our enormous thanks to everyone on the IPCC side, it's incredibly important, so thank you. We'll then move on to the risk management side, the board assurance framework and risk quarterly report. Anne, what would you like to pull out here?
Yeah, it's just this covers the period up to Q3. It's been reviewed at Risk Management Board. It doesn't highlight any particular concerns. It does flag our highest current risks, and that includes the financial challenge faced by the Trust and other organisations in the local health economy. So that's the main point I wanted to draw out.
Great, thank you, Anne. Any questions or perspectives to Anne? Just one from me, Anne, which I'd quite like in a relaxed way you to have a chat to Rosemary about, which is, if there's one thing that's COVID taught us, in my opinion, it's the very, very low probability events which have an enormous impact. And so I would just like us to ensure ourselves that we've thought about all of the really low probability situations that could arise, but the consequence, if they did arise, are dramatic. And I think that's one of the things that COVID has hopefully taught the nation is it might be very low probability, but if it does happen, the situation is critical. So if we could just, you and Rosemary, maybe talk about that a bit, just to make sure we're not missing anything obvious. Colleagues, happy to move on? So we've got then a summary of ratified policies. There
is just one policy covered, and it's the domestic abuse and sexual violence policy. And the paper that you've got sort of provides an overview and a summary of this very important policy, which will act as a really useful aid memoir for our staff.
Super, thank you. Any questions to Anne? And then we're on to the appointment of the 2 consultant radiologists. Anne Pope, just for noting.
Yeah, just for noting, but 2 great appointments, hopefully.
Fantastic, and we've been waiting for a while for those, so really great to have them on board. Any questions to Anne? And then the Registration Authority Annual Report and Emergency Planning Annual Report. Helen?
I have nothing to add to the reports, Chair, just take them as read.
Thank you. Any questions to Helen? Thank you, colleagues. And then the Audit Committee of the 14th of October. Seems like a moon ago, Rosemary. Anything you'd like to add to those minutes?
Nothing to add. Thank you.
Thank you. Any questions from colleagues? Then the clinical governance of the 11th of November, the 9th of December. Bruce, anything you'd like to add?
Nothing to add. Happy to take questions.
Thank you, Bruce. Any questions to Bruce? And then the F&P of the 3rd of November. Simon, anything you'd like to add?
Nothing to add, Russell.
And any questions from colleagues? Any other business? Please raise your hands if you've got any other business. Okay, I think we've then got some questions from members of the public. Sarah, colleague, could you read out the questions that we have had?
Yeah, thank you. So we've got a question from a public governor, which is many staff have to use their holiday entitlement within the financial year, but with COVID, many will not feel able to do so. Once COVID pressures have eased, presumably pressures will be on staff to catch up on delayed operations and investigations. What steps are the Trust taking to ease this problem? And I think Anne Pope's going to answer this one.
Okay, thank you, sir. I think that question was asked by David G. It's a great question, David, so thank you for asking it. Anne?
Yeah, and I touched on this in my report earlier. So the well-being of our staff, as you would expect, is a high priority. And every year we encourage staff to take all of their annual leave and to take it at regular intervals during the year. During this year, we've particularly focused on that. So trying to make sure that our staff get regular breaks. We've reported on a quarterly basis to managers and encouraged managers to support staff to take their holiday. We do have a policy that allows staff to buy or sell up to a week's leave if they wish to. For many of our staff, this gives them the flexibility to support a plan for a special holiday the following year or something like that. And we have had more staff sell leave this year than buy. In addition, we do allow staff to carry over up to 5 days of annual leave at the end of the year, but that is only related to exceptional service needs. So we don't encourage that, but where staff have been willing, and many of our staff have, to support areas, then we do allow that carry forward in addition to the opportunity to buy and sell leave. We haven't increased that this year, so we're still, we don't want our staff carrying over more than a week. We're fortunate in the NHS that our leave entitlement is quite generous. So we don't want to add to the burden of that next year for managers who are trying to plot annual leave through the year. So hopefully that gives assurance that the well-being of our staff is paramount in this.
Thank you very much, Anne. And Sarah, were there any other questions that we've been notified of?
Jane Knight, Public Governor, she'd asked a question, but Glenn has answered that and referred to it in his Chief Exec's report section. So that's it. Okay,
great. Thank you. Just for a couple of minutes, just because I want to make some concluding remarks, going back to Captain Sir Tom Moore. Any other questions from members of the public who are on the line? Please raise a digital hand. Okay, so I'd just like to make some concluding remarks again, just going back to the example of Captain Sir Tom Moore. He obviously raised 33 million for the NHS without any sort of requirement as to how that money was spent. He did it out of the goodness of his heart to support our staff. And for members of the public, if you like, our share of that, which comes through the NHS Charities Together, was around £175,000. And because of the work of Sir Tom and other members of the public who have raised money for NHS, some of the things we've been able to do during the pandemic include providing care packages for frontline staff. We've provided staff wellbeing rooms on the hospital, enabling staff to spend break times away from clinical areas, and they've been stocked with drinks and treats to keep staff going. We've been able to fund 2 posts for 12 months. One post is for a psychologist, one is for a physiotherapist to provide additional support and support the mental and physical well-being of staff during the pandemic. We've been able to refurbish staff areas to create more comfortable environments. We've been able to provide iPads for patients, enabling them to interact with loved ones at home. and we've been able to fund patient activity packs to keep patients entertained. And that's included things like puzzles and pens. So a whole variety of things. So because of the great fundraising that Sir Tom did, without any sort of requirement as to where the money should be spent, but making it available for the NHS to spend it in the right way. He is a fantastic example for all of us to follow, and I can't think of a better note on which to end the public board. I look forward to seeing members of the public at the beginning of March. There is the Council of Governors meeting next week, which members of the public are able to join digitally. In the meantime, I look forward to seeing you all soon. That's the end of the public meeting. For executive directors, we'll give ourselves a 10-minute comfort break, and then we will start the confidential board at 10 to 4. I look forward to seeing you soon. Thank you very much.